Okay, that's 2:30. Everyone, please take your seats and we'll finish up our last two programs. Okay. So as many of you have figured out, if you've completed your scavenger card, you can just go ahead and just fold it in half and put it right in the red drop box at the back of the room. We'll use that for the raffle drawing at the end of the day. And then if there are no other questions, we'll go ahead with our last two talks. So it's my pleasure to introduce Dr. James LaBelle, who is an associate professor and physician scientist at the University of Chicago and the Comer Children's Hospital. He is trained in pediatric hematology and oncology and focuses on transplant and cell therapies. He serves practically as the head of our transplant work group at Comer. He's a very active and productive research laboratory focusing on cancer immunology and therapeutics with a dozen+ trainees and researchers. And he has personally mentored, either clinically or through his laboratory, several dozen physicians and researchers. James is a phenomenal teacher and a steady champion of our clinical services, and I'm very grateful to get to work with him and very excited for his comprehensive review of the latest cutting edge in the treatment of sickle cell disease. So everyone, please welcome Dr. James LaBelle.
Thank you. Can you hear me okay? I put this on myself, so okay. I just want to personally applaud Dr. Baratow and her team again. I think that I'm going to put a motion in that there be an award next year for disaster relief or something like that. I don't know. I was on pins and needles the whole time, and I know our hospitals communicated during that time, and it was for pediatric care. It was striking.
Your way. That's not helping.
Oh yeah,
that's not helping you at all.
Well, thanks, Tim, and thank you for the organizers for allowing me to talk a little bit about our experience with gene therapy for patients with sickle cell disease. These are my disclosures. I thought today I'd talk a little bit about an overview of sickle cell disease. I don't really need to go into depth for this audience, and some current therapies, what our experience has been at the University of Chicago, talk about the FDA-approved cell and gene therapy pipeline. And I wanted to talk a little bit about apheresis considerations. And the reason is obvious, but we actually just we're putting together right now from a clinical perspective to be published soon, apheresis considerations for patients with hemoglobinopathies. So I hope that you find that informative. We'll talk about the treatment journey, a typical treatment journey with gene therapy, and our workflow for patients. So sickle cell disease, as many of you know, or may know, it was actually first described in the Western world by Dr. Herrick, who was a physician at Rust University here in Chicago. And it was discovered and described as a sickle-shaped red blood corpuscles in 1910. And it was discovered because at that time there was a dental student from Grenada, a 20-year-old dental student, and he's there, who was severely anemic and experiencing pain episodes. And when they looked under the microscope, this is actually the pictures from under the microscope, they saw these sickled shapes. Historically speaking, again, that was in 1910. And if we think about the trajectory and the history of where we are now, I think this is fairly impressive because we've gotten to, from 1910, the first discovery of this disease, to now a transformative gene therapy. In 1927, there was a lack of blood oxygen was identified as a factor with sickle cell disease. Sickle cell was named the first molecular disease in 1945. And then but it wasn't until 1957 that the cause of sickle cell disease was determined. In the 1960s, blood transfusions were really the only way to treat this disease. And it wasn't until 1972 that the federal sickle cell programs were established throughout the country. And I'll talk about that in a moment. New York was the first state to screen infants for sickle cell disease, and that was back in 1975, followed by, in 1984, the first described, supposed to be first, bone marrow transplant for sickle cell disease was described in a patient. In 1989, Illinois started screening infants for sickle cell disease, and it wasn't until 1998 that we had our first FDA-approved therapy for this disease, which is hydroxyurea. In 2007, BCL11A, which is a transcriptional repressor, which is going to be very important for the talk today, was found to be associated with hemoglobin F, or fetal hemoglobin. This was done in large part by Stu Orkin at Boston Children's Hospital. In 2008, the UN declared World Sickle Cell Day. And it wasn't until 2017 that we had our next FDA-approved drugs for this disease, which was hydroxyurea and L-glutamine together, was approved for children. Crizanlizumab and voxelotor, which is no longer FDA approved, was happened in 2019. And then Casgevy and Lyfgenia, which were the FDA approved products for this, gene therapy products were approved for this disease on December 8th, 2023. As you know, the symptoms of sickle cell disease occur during infancy as gamma globin gene transcription switches to beta globin, and you can see that here, causing a shift from fetal hemoglobin to adult hemoglobin, which in this case would be sickled hemoglobin. The induction of fetal hemoglobin has been a proven strategy for treating sickle cell disease. This is where hydroxyurea comes from, where there's a naturally occurring benign genetic condition called hereditary persistence of fetal hemoglobin, or HPFH, which produces pancellular distribution of fetal hemoglobin in red cells. And it's this persistence of fetal hemoglobin that ameliorates symptoms of co-inherited sickle cell disease. And as is shown here, the shift between fetal hemoglobin and adult hemoglobin occurs right after birth and is really mediated by this BCL11A transcriptional repressor. And how this works molecularly, this is my only real molecular slide, BCL11A is a transcriptional silencer. So it silences gamma globin expression and thus represses fetal hemoglobin production. And the way it does this is how all gamma globin genes are transcribed. There's a locus control region, which is about 6 kilobases upstream of the globin genes. And you can see that there's a host of transcriptional factors and repressors and activators, which bind the locus control region. It folds over on itself, and you get timed transcription of the beta globin. BCL11A binds these components and does not allow them. BCL11A binds upstream of these other gamma globin loci, preventing the locus control region from binding there, and then switching, therefore, to beta globin. So the molecular basis of sickle cell disease, as you know, is an autosomal recessive disease characterized by mutations in the hemoglobin beta gene, and it's most commonly at the 6th position, which is shown here, a glutamic acid for a valine. And we know that sickled hemoglobin polymerizes under hypoxic conditions, producing deformed red blood cells that hemolyze, causing anemia and vasoconstriction that results in progressive organ damage and early death. Here's the estimated number of births with sickle cell disease in the last decade or so. And you can see that this is a worldwide problem. But you know that most patients with sickle cell disease are still in sub-Saharan Africa. Some history about the sickle cell disease. I like this sort of history of this kind of stuff, as it was detected in the United States. It was really because in the 1970s, the Black Panther movement was instrumental in actually getting sickle cell disease being part of the public register. And so the Sickle Dex, which was first produced by Ortho Pharmaceuticals. And then actually when they would run out of this, there was a chemistry graduate student at Harvard named Bill Wallace, who would actually take blood samples from these pop-up vans and go to the lab at night and do his homemade Sickle Dex screening for patients. It wasn't until 1972 that the Black Panther Party was really the driving force for the National Sickle Cell Anemia Control Act, bringing 1975, the first state, as I talked about, and the Illinois Department of Health piloted this in 1988 and made it a law in 1990. And it wasn't until 2007 that all states have newborn screening programs. And this was fundamentally a game changer, because the early identification, education, and initiation of penicillin in these young kids decreased mortality within the first 5 years of life from 25% to less than 2% in the United States. And it looks like this. You can see in 1970s, this was sort of the curve of patient deaths. from sickle cell disease. And you can see a large number of deaths in the United States in the early childhood period before neonatal screening. We know that sickle cell disease affects about 100,000 Americans, but there are 300,000 people with sickle cell disease born worldwide. Unfortunately, 11% of these patients will develop stroke by 18 years of age. And the median survival in 1978 to 1988 was between 42 and 48 years, depending on sex. And unfortunately, we have not done a very good job of moving that curve over the last few decades, because between 2003 and 2006, the average life expectancy hardly moved. And much of this was because of our neonatal screening. But what we were doing for these adult patients was not adequate. So the only curative treatment so far is an allogeneic stem cell transplant. Again, this requires finding a matched donor, which in this patient population occurs in about 17% of the time. And it comes with a healthy risk of graft versus host disease. We know that the abnormal hemoglobin in sickle cell disease results in polymerization and deformation of the red blood cells, which is shown here. This alteration and deformity leads to red cell dehydration. And this leads to oxidative stress, which is both a cause and an effect of hemolysis, which further damages the red blood cell. This leads to a vicious cycle of hemolysis, which releases free hemoglobin, which this forms more damage. Red cell damage further affects nitric oxide handling and results in vasoconstriction, in addition to activation of platelets and other coagulation factors. The innate immune system is also activated because of the damage to the erythrocyte membrane. And these changes greatly affect the endothelium and cellular adhesion in every organ in the body. In fact, the effects of sickle cell disease varies greatly in people, right? But unfortunately, in many cases, only once complications have set in do we have a better idea of the long-term morbidity and mortality in an individual patient. And this is why this is one reason why it's been historically difficult to decide which patients should proceed to transplant and which shouldn't. But it's making it a little more easy because we know the trajectory of this disease to get these people gene therapy. So highlighted here are some of the chronic complications and key organs from the disease. Again, no organ is spared. And we shouldn't forget about the psychosocial ramifications secondary to the loss of school, chronic pain, pulmonary disease, and significant challenges for patients to attain educational, social, and psychosocial age-appropriate goals, which is shown here. So again, until 2017, we were really limited to two disease-modifying therapies. One was hydroxyurea, and one came from all of you, which was chronic blood transfusions. And then in 2017, we had two other drugs that were FDA approved, but one is now taken off the market, and we just have another one. So the question is, how can these agents, these limited agents, optimize patients for transplant or gene therapy? And there's risks to each one of these, right? Hydroxyurea, there's some digestive side effects. You have to take it every single day. You can get skin ulcers. You can get canker sores. It's a chemotherapeutic, so you get low blood counts. You can get mild hair loss. And because you have to take it every day, I don't know if you're like me and you take a 10-day course of amoxicillin. On day 8, you're like, I'm good. And so imagine taking this for the rest of your life. Chronic monthly transfusions, I don't need to tell you about the risks of those. Of course, allogeneic stem cell transplant, there's graft versus host disease, which is higher in this population because of a lifelong history of inflammation. Graft rejection, graft failure, and other transplant-related complications. And these newer therapies, we really don't know because we haven't been around long enough outside of hydroxyurea. So the resultant healthcare costs are really high, with the total healthcare system economic burden of sickle cell disease estimated to be about $3 billion per year in the United States. And half of this is due to inpatient costs, the other to outpatient and out-of-pocket costs. So there's lots of stem cell-based options for sickle cell disease. I'm not going to talk about the first ones. I'm going to talk about the blue highlighted topic, which today is gene therapy. So what is gene therapy? I know all of you know this, but I'm going to review it anyway for those who may not be familiar with this. Well, so gene therapy involves modifying a cell's genome and includes various approaches like gene editing, which is shown here, and gene addition. So gene editing aims to alter a patient's DNA within target cells by modifying selective genes. This is done nowadays through base editors or CRISPR technology. And then there's gene addition, which actually addresses a faulty gene by adding a functional copy or inserting a different gene to replace that dysfunctional gene's place, right? So here, let me go to my next one. So CRISPR, this is not a talk on CRISPR, but the CRISPR technology is shown here. It relies on an RNA-guided nucleases. There are two versions right now that are going into people. One is CRISPR-Cas9 and one is CRISPR-Cas12. They're both for site-specific target DNA recognition and cleavage, which is shown here. Cas9 utilizes a single guide RNA, and Cas12 uses something called a CRISPR RNA guide. These target DNA recognition areas and is dependent upon the complementary binding of those guide RNA sequences and the presence of an adjacent motif, a protospacer called a PAM motif, which is shown here. Upon binding, whether it's Cas9 or Cas12, you get nucleases that bind and cleave the DNA, and you generate two important things. One is double-stranded DNA breaks, right? And these double-stranded DNA breaks by cellular DNA repair pathways. And this leads to genetic modifications like insertions and deletions. So these are the indels. You can also have homology-directed repair, where you can actually exogenous DNA repair templates can be inserted into the gene. And that's going to be important when we talk about sort of the new technology nowadays. Gene therapy viral delivery is a different context. So CRISPR-Cas9, there's no foreign material in the cell, actually. But with gene delivery, there is foreign material in the stem cell. And the ones that are FDA approved use lentiviral or retroviral based gene insertion. And we're not going to talk about these other ones for right now. And it's really fundamentally unbelievable to me that CRISPR, the whole CRISPR technology was actually discovered about 15 years ago and is now actually in patients, which is remarkable, right? We just talked about 1910 when it was first, and it took over 100 years to get something into patients. So the pace at which gene therapy is going to be in all of our doorsteps is, it's going to be like drinking from a fire hose. And ex vivo delivery of gene therapy for sickle cell disease actually went through a much slower process. You can see that the identification of the globin regulatory elements, or that LCR, was done in 1984 and 1986. And we didn't get really the use of lentiviral vectors until about a decade later. And we didn't get to clinical trials with lentiviral gene addition for this disease until 2008, which was when it was first successfully done in a patient with beta thalassemia. And it wasn't until 2015 that patients with sickle cell disease were added to this therapy. So remarkably, from 2015, and it took until only 2023 for these to be FDA approved. So these are wildly successful and transformative therapies for patients with a life-altering disease. And I'll just tell you a little bit about our experience. So we worked with a cohort of hospitals, St. Jude, MSK, Children's Hospital Los Angeles, and a hospital in Italy. And the idea was, could we reenact hereditary persistence of fetal hemoglobin in patients' stem cells by targeting not BCL11A itself, but target where it bound on hemoglobin gamma 1 and gamma 2 promoters. And again, we know that hemoglobin F ameliorates symptoms and complications to sickle cell disease. And we know that the interaction of all those transcription factors that I talked to you about before actually binds to the gamma globin loci, and there's two of them, gamma 1 and gamma 2 promoters, and these are responsible for that switch. So if we could somehow prevent BCL11A from binding to those promoters, perhaps we could trick the LCR apparatus to still make fetal hemoglobin. And it looks like this. So how can we do this? So this is chromosome 11. You've got the locus control region here. You've got the hemoglobin genes here. Here's gamma 1 and gamma 2, which encodes fetal hemoglobin. And here's the adult hemoglobin. And here's BCL11A, which is this is an enhancer region, and this is on chromosome number 2. So the way this worked was BCL11A normally binds these genes, not allowing for that LCR to skip and transcribed adult fetal hemoglobin. CRISPR-Cas9 was then used, can be used to actually get rid of where BCL11A is actually made on chromosome 2. This was not the therapy that I'm going to talk to you about, but this is the underpinnings of one of the FDA-approved therapies, which is from Vertex, which is a hexagamglogene autotemcel. I'm going to call it not that. I'm going to call it Casgevy. And what was remarkable is when they got rid of BCL11A, hemoglobin F rose to about 40% in patients, which is far beyond what you can get normally with hydroxyurea. But the question is, we don't really know how important the BCL11A is for other enhancers, for other genes, right? So the way we went about doing it was a little bit differently. We took CRISPR-Cas9 and we said, well, let's not get rid of BCL11A. Let's get rid of where it binds on these promoters. Therefore, you still make BCL11A, and BCL11A is able to do whatever it's supposed to do. And this actually is the underpinnings of the Novartis trial, the Editas trial, which is currently going on, and a St. Jude autologous gene editing protocol, which is ongoing right now. So in our experience, the product was called OTQ923. It was an autologous ex vivo CRISPR-Cas9 edited CD34 cellular product. It was manufactured from cryopreserved peripheral blood-derived CD34 cells. And this was after plerixafor mobilization. And the reason for this is because if you remember that map of the world where all the people with sickle cell disease were, they can't fly a plane every single day to get fresh CD34 stem cells that have been collected that day to a manufacturing facility in Germany. And so the idea behind this protocol was, well, there's many facilities in those regions which can actually harvest peripheral CD34 cells and freeze it on site. And if we could then collect all of those things and then send them for manufacturing in bulk, perhaps we could get at parts of the world where that was used by this CRISPR. It targeted both promoters on hemoglobin G1 and G2. And the reason why that's important because we made indels as well as large regions that were lopped out of the genome. The other unique thing about this is that in order to grow the frozen stem cells after they were thawed, they used a aryl hydrocarbon receptor antagonist called LHD221. And this was to preserve the stemness of the gene-edited stem cells. The study design is shown here. Participants had at least 3 of the following indicators. And this really holds true for for the FDA-approved products as well. You have to have vaso-occlusive crises within the last year, 2 episodes of greater than 2 episodes of acute chest, reoccurrent priapism, history of prior stroke, need for chronic transfusions or red cell alloimmunization, and the trial objectives were here. But I want to point out that while you could have had a history of prior stroke, this was the only study at the time that allowed participants to have a history of prior stroke, because the FDA approved products is not approved for that. And actually people don't do that because we're not quite sure yet if we can actually take the risks of taking off chronic transfusions in those patients is too great. And so we're studying that right now. The journey sort of looks like this. So you screen a patient, you mobilize a patient, and you provide apheresis, and we'll talk about this more. You collect this, we froze the samples, you isolate the CD34 cells at the manufacturing, you culture them in this aryl hydrocarbon. You then add the CRISPR apparatus through electroporation. Again, this is not lentivirus. You expand them some more. You then cryopreserve the stem cells. And while that's happening, you then bring the patient in for an autologous stem cell transplant, and you condition them with a mono chemotherapy with busulfan. So it's bone marrow depleting, high dose chemotherapy, but it's a single agent, which is busulfan. We then infuse these as we would an autologous stem cell transplant, and we wait for engraftment. The report originally talked about, there were 3 patients in this report, but now there are 6 patients who have been treated with this. And you can see that the age at screening, they were all AYA patients. There were 2 males and a female. They all had homozygous sickle cell disease, and they had really terrible sickle cell disease. These were, if you look at the kind of sickle cell disease that these patients had, it was beyond some of the other trials. And the reason we did that was to see if we could actually raise the hemoglobin to a point, or raise their hemoglobin to a point where we would actually make a fundamental difference in some of these like terrible ACSs and history of prior stroke. These were some of the treatments that they used beforehand, and the outcomes are shown here. So the cell dose that was manufactured, it was very difficult to manufacture in this case, and we'll talk about this in a moment. We had, you can see that it was between 2.8 and almost 6 CD34 high expressing or bright expressing CD34 cells million per kilo. And you can see that it required numerous plerixafor mobilizations in these patients because it's actually quite difficult to mobilize and collect CD34 cells. This is an autologous stem cell transplant, so they engrafted nicely. They also had platelet engraftment. And at the time of this publication, they were out this long, but now these patients are out to 2.5, 3 years. I will say, after this treatment, there was one episode of VOC and acute chest syndrome in one of the patients at 17 months. And this patient still had recurrent intermittent priapism. There were no CNS changes. This person also had an episode of VOC and no ACS or other problems, but also had persistent osteonecrosis of the femoral head. And this patient also had one episode of VOC, some mild hemolysis, and had persistent osteonecrosis. That's other caveat to this kinds of therapy is that prior damage from sickle cell disease, this does not cure, obviously. So if you have bony infarct or osteonecrosis damage to your bones, you still have pain like that. But none of these patients were otherwise hospitalized. And if you look at their blood parameters at this time, this is total hemoglobin here. You can see this is when they were screened. You can see their percentage hemoglobin F was non-existent in all cases, shown in green. Sickle cell hemoglobin was shown here. These guys were getting exchange transfused. That's why you see a lot of hemoglobin A. They were brought in for their transplant, and you can see that their hemoglobin A went down as their need for transfusions went away. And you can see that they still made hemoglobin S, but now they made persistently high levels of fetal hemoglobin. And when you looked at the cellular expression of fetal hemoglobin, it was pancellular. So it was near 100% of all of their red blood cells. And this is despite making sickled hemoglobin, you didn't have a lot of hemolysis because of this, and they had high hemoglobin levels, and you can see that here. You can see that there were no associated adverse risks, events from getting the product, and all the patients have been transfusion independent following this procedure. Here's one patient that was in the news and sort of on the Tribune, and you may have seen her. Her name is Lyric. She's now 2.5 months, 2.5 years after this therapy. She's gone on, her quality of life has improved, but unfortunately, this is one patient. Lyric had a lot of osteonecrosis prior to coming into transplant. She still suffers from chronic pain from that. So this was the first clinical evidence that targeting the gamma globin regulatory region resulted in stable fetal hemoglobin, and it offered a treatment option for these patients. It increased total hemoglobin levels in a meaningful and durable benefit way. There were no new complications. The safety profile was okay. Here's the note. Because the level of fetal hemoglobin by targeting the promoters was around 25 to 27%, we didn't feel it was quite enough to prevent some of these VOC risks because they still had minor amount of hemolysis. And so all three of these patients are again on hydroxyurea to somehow raise their fetal hemoglobin a little higher. So let's talk a little bit about the FDA-approved therapies. There's one gene editing approach. This is the Casgevy product. It costs $2.2 million. The gene addition approach is Lyfgenia. This was the Bluebird product. This cost $3.1 million. So these are completely unaffordable to anyone, I would wager. And actually, I've been working on the governor put together, or whoever told the governor to put together, but the governor put together a task force to figure out how to get these gene therapies approved for patients in Illinois. And actually, I have to say, we've never been not approved from a Medicare or Medicaid perspective in Illinois. So let's talk about how Lyfgenia works. Lyfgenia is the gene insertion, right? So this is a lentiviral vector, and this is a non-sickling hemoglobin. So they actually put in a a beta globin with a mutation at position 87, a T87Q mutation. And this recapitulates actually what fetal hemoglobin does. So fetal hemoglobin also has this base pair. And what happens is if you combined adult hemoglobin and sickled hemoglobin, it's not a very good job. It's a relatively weak inhibitor of sickled hemoglobin polymerization. It doesn't work. But if you have fetal hemoglobin and you've got sickled hemoglobin, it doesn't polymerize very well. So this was the idea. And so I'm not going to go through this. And so it turns out that this tetramer of sickled hemoglobin right here, and this lentiviral induced non-sickling hemoglobin, you don't get the polymerization of these hemoglobin molecules. Now you have a lot of hemoglobin in your cells because it's a lentiviral vector in gene addition, but you don't get hemoglobin. And this was amazing because there was an immediate decrease, but followed by stable vector copy in peripheral blood of patients, and that's shown here. There was stable expression of this beta globin in patients, and you can see here. So just like the other graph, this is a little bit different. Here you can see this is sickled hemoglobin in green after the transplant, and this is that non-sickling hemoglobin here. There's no fetal hemoglobin whatsoever here. It's just non-sickling hemoglobin and sickled hemoglobin. But you can see that these patients' mean hemoglobin level rose to about 11, which is near normal, which was really remarkable. And if you looked at its efficacy, each one of these lines in the swimmer plot represents a single patient. And you can see here on the right, or is it your left? These are severe VOC events, and these are all VOC events, and they're just littered with severe VOC events prior to the infusion of their autologous gene-edited stem cell transplant. And you can see afterwards, they had no severe VOC events, but some patients did have a few non-severe VOC events that didn't bring them to the hospital. So this changed people's lives. The other approved therapy is Casgevy, which is the CRISPR-Cas9 mediated therapy for sickle cell disease and beta thalassemia. Again, rather than targeting the promoter regions, now you target BCL11A itself on chromosome number 2. And you can see this was also a game changer. And you can see here, again, if you look at fetal hemoglobin, which is in blue, before transplant, you didn't see that. After transplant, the levels of natural fetal hemoglobin rose to about 40%, which is pretty incredible. But they still made sickled hemoglobin, and you can see that here. If you look at the pan distribution of fetal hemoglobin, you can see it was indeed distributed in all red blood cells. And so this led to a decrease in hemolysis. So while these patients made sickled hemoglobin, they didn't polymerize. And again, if you look at these sort of plots again, you can see these are periods from severe vaso-occlusive crises right here. And these are inpatient vaso-occlusive crises. And you can see, again, all of these patients are littered with VOC complications. And then afterwards, you do see a few of these patients having VOC crises. And these are patients that had pre-existing disease prior to coming in, like bony disease or priapism. Things like this. And you can see that, but hospitalizations were very few. So this actually was a game changer. And these are the 2 FDA approved products right now. So what does the patient journey look like for these patients? Unlike transplant, where you can get a patient to an allogeneic stem cell transplant in a matter of a couple months, this treatment journey takes about a year. And the reason for that is because you identify a patient that takes 4 to 6 weeks. And we'll go through these in a moment. You have to pre-mobilize these patients. You need to quiet their bone marrow. You need to give them exchange transfusions for a minimum of 8 weeks. You then mobilize and collect their stem cells. That's up to about 3 days, each inpatient hospitalization. The product is manufactured, takes between 4 and 6 months, actually, to look for genetic changes to make sure there's no mutational effects. The patient then comes in, they get preconditioned with busulfan. They get their autologous stem cell transplant. They're in the hospital for approximately 6 weeks. And then there's a follow-up. And now these patients are followed up for at least 15 years now on national standards. The patient selection criteria is these therapies are only FDA approved for patients who are 12 and up. And this is sort of a problem. You just said that 11% of these patients up to 18 develop stroke, right? So we want to actually treat these patients a little bit earlier. And there are trials right now looking to see how low we can go safely in patients with sickle cell disease up to below about the age of 2, to about the age of 2. To qualify for these from a health insurance perspective, you need to have at least 2 of these, which are 2 VOC events during the last year or in a 2-year screening period, or these other things, acute chest syndrome, priapism, or splenic sequestration. Exclusion, there are many right now. Advanced liver disease, untreated moya-moya, anything that puts the risk for CNS bleeding, and history of abnormal transcranial Dopplers, the need for chronic transfusions. These are all the things that we've gotten lots of consults for patients to come and get gene therapy, and we just don't yet know if we can get rid of the need for chronic transfusions. They need a normal stem cell transplant workup. And I want to talk a little bit about what is needed for pre-mobilization and mobilization itself. So we need to at least have red cell exchanges or at least simple transfusions, but most centers do red cell exchanges for about 8 weeks prior to mobilization. Just reduce the number of sickled cells, and it allows for quieting of the bone marrow to bring that erythroid to myeloid ratio back towards the myeloid ratio so we can actually collect the stem cells. And then we do this again right before you come into the hospital to decrease sort of collection, sort of catheter insertion problems for patients with sickle cell disease. We use plerixafor. We can do this for at least up to 3 days in a row. So these patients are admitted to the hospital. And we look at CD34 counts before, during, and after plerixafor mobilization. And you need a lot, and we'll talk about this in a moment. So here's some considerations regarding apheresis. The collection of adequate CD34 bright cells, which are the long-term hematopoietic stem and progenitor cells, can be extremely challenging in this patient population. We can collect CD34 cells, but it can be extremely challenging to get the CD34 bright cells. This requires a multidisciplinary team of hematologists, transplant physicians, transfusion medicine, apheresis groups, and nursing specialists. There has to be coordination of line placements. So you need an apheresis compatible catheter. This is usually a temporary non-tunnel central venous catheter that is put into place right before the collection and then taken out. And if you have to repeat this 2 or 3 times, this can be quite laborious for the patient. Generally, we would like to get a large volume leukapheresis, which is greater than 4 blood volumes. This can take a long time during the day. So this needs to start really early in the morning because there's a plane waiting for these stem cells at O'Hare or somewhere, and they have to be flown that night to their manufacturing facility. The target cell doses for the 2 FDA-approved products are shown here. The goal is to target between 15 and 20 million CD34 bright cells per kilogram patient, and then you keep some stem cells that are unadulterated on site in case there's graft failure and you need to reinfuse stem cells. The collection procedure optimization is shown here. Sickled cells have altered RBC morphology and these patients are hypercoagulable. There's high levels of RBC neutrophil and monocyte and platelet neutrophil monocyte aggregates. There's can be a lot of difficulty in establishing and sustaining an interface when collecting these patients. Generally, targeting a deeper collection depth captures more of these CD34 cells, but you could have increased RBC contamination. And the optimal anticoagulant in these patients is not yet defined. The most common anticoagulant is ACDA, but some centers will also titrate in heparin. This will allow higher inlet flow rates. And to allow for that long-term collection. In our center and some other centers, but this is not universally adopted, we actually give the patient a daily aspirin as well to reduce microclotting. What happens if the adequate stem cell collection is not achieved or if that product is not manufactured? Because you need at least 3 million cells per kilogram to be manufactured and infused in the patient. And what we're finding in the real world data is this, in about 30% of the time, takes at least 3 of these admissions and stem cell collections, which is a lot for a patient. Of course, we can't give these patients GCSF. The age of the patient, baseline levels of marrow inflammation, severity of disease really affect stem cell collection. Patients on study, I told you, needed many of these mobilizations. And people are actually studying now motixafortide, which is like plerixafor, but it has a very high affinity and long engagement with CXCR4. And this is currently being tested in patients with sickle cell disease. It's FDA approved for patients with multiple myeloma. And this goes to show you how difficult it is to collect stem cells from these patients because of disease severity and age. Really impact the ability of plerixafor to release CD34 bright cells. And you can see here in part A, these are the total CD34 cells per kilogram that you can collect. And if you look at their pre-apheresis CD34 count, obviously, if you have a high pre-apheresis CD34 count, you collect more. That doesn't come as a surprise. The younger you are, the higher CD34 dose you get. So remember, I just told you that this is only FDA approved for patients 12 and above. So we're getting lots of adults who really want this. The problem is when you're in your 30s, it's really difficult to get a high enough number of CD34 cells that can be manufactured into a usable product. And this is why people are struggling collecting these patients. Really is no difference between if you're a male or female, but there is a difference between how sick you are. And so if you look at the total number of CD34 cells and the number of hospitalizations you've had in the last year, or the number of medications that you use to treat sort of chronic pain, which is a secondary measurement of how severe your disease is, you can see that the lower number of hospitalizations and the lower number of medications that you use, the higher number of CD34 cells we collect. So getting these patients earlier, we think will provide a benefit to actually getting manufactured product. And how long you hold hydroxyurea, which I didn't say, was during these exchange transfusions as these patients are coming to transplant or coming to apheresis, we actually hold their hydroxyurea. And we know that the longer you hold hydroxyurea, the better your stem cell collection is. And in the early studies, these hydroxyurea was held for a couple of weeks, and people were really having a difficult time getting adequate CD34 cells for production. And now we hold it for a minimum of 2 months. I talked to you about the manufacturing period. This is a long period of time. There's a lot of quality release testing before shipment to the center. And during this time, we offer fertility preservation. We do a disease workup for all the things that we need to do. And many times we'll still precondition these patients with RBC infusions during this time through exchange transfusions. They're then admitted for a myeloablative conditioning. Here, they get 4 days of busulfan, high levels of busulfan. We can dose this based on PK levels, pharmacokinetic levels. In children, we do this with 16 doses of busulfan. For adults, they do this generally with 4 doses of busulfan. We then await for neutrophil and platelet engraftment and monitor for bleeding, infectious complications, as you would normally do for an autologous stem cell transplant. And you can see here that the follow-up is relatively intense, up to about 100 days after treatment. The post-transplant follow-up looks like this. They need blood transfusions if they need them. Actually, interestingly, these patients rarely need blood transfusions after they're discharged from the hospital. We can restart iron chelation if they've had a lot of iron overload. Pain management is needed. There's lots of lab work. We do bone marrow biopsies at 6, 1, and 2 years to look for any sort of mutational changes in autologously reconstituted busulfan exposed stem cells. And we check other organs, things like that. So, in conclusion, this is really a mechanism-based genetically modified cellular therapy development is essential for effective long-term durability in these patients and other patients, and to prevent any untoward, off-target, and on-target unintended effects. And as that looking at these off-target effects is what takes so long right now in the production period. We don't know yet which one is better, actually. We don't know if a CRISPR-Cas9 BCL11A strategy is better, or a lentiviral non-cycling hemoglobin is better. We will say if you've got alpha thalassemia, we prefer to use the CRISPR-Cas9 agent because of your hemoglobin content with added lentiviral non-cycling hemoglobin. Long-term safety and efficacy data is still needed. And this is opportunities for new organ-specific analyses in these patients who are post-gene therapy. We're making whole new patient populations that we need to study. How do we make decisions? So how to select patients for either a transplant or gene therapy remains very complicated and a little bit center specific. And it also is dependent upon hematology buy-in as well as stem cell transplant and gene therapy buy-in, right? There needs to be a real coordination of effort between those two groups. And you can see that if you look at the risk of transplantation-related complications are shown here, and you look at age of the recipient, you can see that the risks of transplant associated complications after 18 years of age get really bad, right? And so this is the challenge right now with patients, whether they get autologous stem cell transplant or they get allogeneic stem cell transplant. And so we're trying to find an area in which gene therapy can be efficacious for younger patients. What we do, we have a sickle cure clinic. We do a pre-transplant phase in which they're seen by all of these services. We have a peri-transplant phase, which they're still seen by these, and there's multidisciplinary meetings, of course, and the post-transplant phase in which they're actually seen by transplant specialists as well as their hematology team. So it's a lot of resources, actually. And this sort of sickle cure clinic and consultation is really run both by a hematologist as well as a transplant physician. So our approach at our center, we're a little bit different. So we're a freestanding children's hospital, but we're not nearly as large as Lurie. And so our footprint is still within the University of Chicago. So we have the ability to sort of take care of patients who are a little bit older than our typical transplant pediatric patients. We will provide therapy for patients of about 30 years and younger. And we need a cooperation between the adult side and the pediatric side at our center. And I'd like to thank, again, the organizers. I'd like to thank everyone and the patients most importantly. But I'd also like to thank all of the people, including Tim and his team, who have been really instrumental at our center in getting these patients across the finish line, which can be really a long, arduous process, and sort of life gets in the way over a year treatment. So I'd like to thank everyone there too.
Any questions for Dr. LaBelle?
Talking about having to do multiple collections of stem cells, are those on back-to-back days, or do you have to space them out?
Yeah, so most centers will admit patients for up to 3 days at a time. The very first collection that you do for that patient, it's always 3 days. And the reason for that is you collect the first 2 days for the product, the third day to keep for your autologous backup. And so most centers will either put in a temporary catheter the morning of collection. The problem with that is it has to be timed really early in the morning, and it also has to be timed with plerixafor. And then Tim and his team need to be sitting at the bedside waiting for the stem cells to pop up. And then it takes 6 to 8 hours, and then they have to eat. So it's a lot of coordination. So some centers, some of the collection days are on Mondays. So you have to either admit the patient on the weekend and convince people to put a temporary line in on the weekend, or admit them on Friday and put a line in, have them sit the weekend and do it. That's how we do it at our center. The next collection dates, assuming you've got enough for an autologous backup, it's only 2 days. So it's a lot. And many times patients develop VOC. I mean, they're uncomfortable. They've got a line in and they're getting mobilized, and you have to treat that as well.
Yeah, thanks, great talk. Thanks very much.
Thank you.
I was going to ask about the transfusions needed for the gene therapy. There's a new paper in transfusion you might have seen online where they try to estimate the number of red cells needed to get the patients through this.
We were just talking about this actually. We were just talking about this earlier.
I think it said to 45 units. For patients with antibodies, that might be really challenging. Does that sound right to you all?
I mean, yeah, probably right.
For N equals 1, we're probably trending a little above that right now.
Yeah.
due to specific idiosyncrasies. I would say as a general estimate, that sounds good. Relatively uncomplicated harvest and collection regimen, 40 to 50 from the span of the very beginning, knowing that these patients have undergo red cell exchange, that probably be the largest source of usage rather than supporting them during the peritransplant period.
It's a phenomenal usage of
Yeah,
blood.
thinking of patients with antibody problems where they're very difficult to find units.
Yeah.
Of course, in the long run, if they don't need transfusions, great, but in the short run, it sounds very challenging.
So I actually brought this up as we were sitting talking before this. I would love to do the power in this room to understand, at least in our local regional perspective. Let's say we had 20 patients with gene therapy in the region, right? Between Lurie and Northwestern and University of Chicago and Rush and UIC and all the other places that do this. If there were 20 patients, what is the blood bank burden for these patients up? Can we even do that? Like, is there a limit to the amount of patients that this region, our local or the city basically can provide? If we do 100 patients with gene therapy a year, is that going to be even sustainable? Right. I would love to look at an analysis of that. I think it'd be quite informative, actually.
My thoughts on that just briefly are that, you know, if you look at the amount of red cells that went to this patient or for other patients who were involved in our previous protocols, again, most of it comes through the red cell exchange protocol, which if you have a patient who's already receiving chronic red cell exchange, then the calculus is a bit different. If anything, the additional burden to get them to the through the stem cell collection and infusion, it may be equal to, or, you know, in the very immediately thereafter will actually be a reduced amount of red cell usage.
Afterwards, yeah.
I think that if you're having someone who does not normally have red cell exchange, you're enrolling them, there's going to be an acute need of a high use during that period. But then there's a good hematologic response. They're actually able to live life in a transfusion independent manner than what we want.
And I would love to use this data to go to insurers and say, there's pain up front, but there's long-term gain from a financial sense, right? Go to the government, go to, Congress and say, hey, you're going to make a lot of the analyses so far on the cost benefit analyses for gene therapy have not talked about transfusional burden or blood bank support that I'm aware of, right? It's all about work-life balance, getting educational, education, ongoing with your education, ED resources, inpatient hospital resources, chronic pain management. But another facet of this is the need for transfusional support after and before, right? And that would be an interesting study. I don't know what that would come to. Yeah.
For the patients with antibodies, which I know maybe it's a hypothetical as well, would all 40 have to be antigen negative? Could you also do like plasma exchange at the same time? Like what would be your thought?
So certainly if you're going to an allo transplant, we do that. We do it, the plasma exchange and then rituximab and the whole bit, right? We have not had a patient at our center that I'm aware of, maybe on the adults, that has had an antibody problem, to be honest with you. So I don't know the answer to that question, actually. Yeah, I don't know. I don't know.
With having not, yes,
Yeah.
My default inclination is that as a worker, our instinct would be to try to provide it would be intelligent to think over the long term and try to do some calculations of whether or not plasma exchange knockout the antibody would be a benefit. But currently we don't have any protocols or SOPs that would allow for, once someone has having an antibody, even if we eventually reduce the titer of at our center, we don't have any protocol to allow for transfusion management. So
that's an interesting question. It's going to come up, right? It's going to come up for sure. It just hasn't for us personally.
I just throw in the other issue, or the other potential future down the road would be FC receptor blockers to reduce the levels of antibody. Adding that on to the next two knockdown patients, that would like to be done for HDNs.
Yeah, that'd be fantastic.
So I'm just curious, with the patient still need consistent transfusions after this gene therapy, you said it, I just missed it, but would they have blood transfusions before?
Yeah. So far, patients have generally not needed any transfusions afterwards. Now, caveat to that is, in both cases, they still make sickled hemoglobin, right? So having sickled hemoglobin that doesn't polymerize is done in two different ways. But if you get a parvo infection, a primary parvo infection, there's actually one patient who got a primary parvovirus infection and needed transfusions transiently until their stem cells came back. Or if you get a really nasty infection of some sort and you get bone marrow suppression, you might have an imbalance of sickled cells, and those patients have needed transfusions. But it's quite rare. Actually, I'll give you an anecdote, which is an N of one. One of the patients on the first study that I talked about, the Novartis study, had a hip replacement after the gene therapy and didn't need one transfusion, that's pretty remarkable for a patient with a history of sickle cell disease.
Just curious, some of the FDA approved ones, they were just approved in 2023, right? So now it's
2023.
About 2 years worth of data so
Yeah.
far. Have any of the stem cell transplants that you have done, any of them reverted back?
So in actuality, there hasn't been a lot of patients yet who have been fully infused for sickle cell disease because it takes about a year. And that year, assuming you were ready to go December 9th, which nobody in the world was. In fact, University of Chicago was one of the first 9 centers in the country to be FDA approved. And we weren't even like able to really consult on patients and have our ducks in a row and all the legal papers that the university wanted us to have, because each one of these is super expensive and on the university's books until like that spring. So it's only now that patients are getting actually infused. So I don't know the answer to that from a real world, but there is a real world consortium looking at just that. Yeah.
Sorry, I have more questions. Okay, so, I know you're trying to get treatment like before 12 years old. What exactly are y'all doing to figure out, like, what kind of testing do you have to do to figure out if they can get it before they're 12 years old?
That's such a great question. It's such a hot topic. One of the terrible things about sickle cell disease, among the other 800 terrible things, is that you can be 5 and have like no symptoms hardly, right? You can be perfectly well and sort of do all the things you do. And then you're a teenager and you're in the hospital every 2 weeks, right? So people are trying to determine earlier biomarkers of disease. Certainly dactylitis, splenic sequestration, pain crises, strokes, all of those are bad things. And those are clear indicators. So people don't yet know, right? Much of this is a discussion with families, right? This is a risk. I showed the curves of the general population of life expectancy with patients with sickle cell disease, and it's not good. It's 25 to 30 years less than the normal population in the Western world. And so we don't yet know. It's a really good question. We'd love to have biomarkers that you could test. But besides those big ones, those organ-related ones, we don't know yet.
Thank you very much. That was very.
Yeah. Thank you.
Need a minute to, yep, thank you. All right, and for our last speaker of the day, I'm going to speak and, oh, sure thing. Thank you, Dr. LaBelle.
You're doing the intro.
Yes, I should be doing the intro. I just need to go ahead and reset this. Give me one.